Okay, we're going to have a narrated lecture on respiratory tube ventilatory disorders, which will cover bronchitis, pneumonia, TB, and fungal infections. First slide talks about ventilation. Ventilation is simply our body's ability to effectively move air into and out of the lungs. Is the pathway clear? Is the airway patent so the air can get to the alveoli to exchange for carbon dioxide? First topic we'll look at is acute bronchitis. Acute bronchitis is relatively common in adults, especially adults that smoke or have immune defense problems. But essentially, acute bronchitis is inflammation of the bronchi diffusely, and it can be triggered by the influenza virus, strep, pneumococcus, staphylococcus. They can all be causes of bronchitis. And then eventually it can roll into pneumonia if it's not managed properly. Acute bronchitis is going to be diagnosed with a chest x-ray. It can be ordered to rule out pneumonia, but it can also be diagnosed with chest x-ray. Your patients are going to experience fever. They're going to have, it's a lot of pain, that burning in their chest, a general malaise, fatigue type feeling. They're going to have a dry cough early, painful along with that cough, and then it's going to become productive with large amounts of sputum. So much so that in the middle of the night especially, they will have paroxysmal attacks of coughing and wheezing. Again, it's terrible at night to the point where they can't sleep. Their airways can become so reactive that they can turn it into having bronchospasms. So then that's really a problem, because then you have an airway issue that you really, truly, your patients are not able to breathe. So we really want to try and medicate them the best we can. So we're going to treat them. Bed rest, bed rest, bed rest. Going to rest and take it easy and really try to recover. Antipyretics for Tylenol for your fever. Expectorants during the day, cough suppressants at night. We really want that night to rest. Pop up on a couple pillows, but we don't want them to get into that point where they have that terrible coughing fit and need you to run into a bronchospasm. Broad spectrum antibiotics, erythromycin, penicillin, that sort of thing. If it gets bad enough, sometimes that they will prescribe Solu-Medrol, because again, it's an inflammatory response in the bronchi. So again, another inflammatory response is acute inflammation of the bronchioles, alveolar ducts, alveolar sacs, and alveoli is pneumonia. It's an infection in one or both lungs. It can be caused by fungus, bacteria, or viruses, but pneumonia causes inflammation in your air sacs or your alveoli. And the alveoli fill with fluid or pus, making it very difficult to breathe. Even so bad so that you can develop an empyema in your lung pleural cavity, which we'll talk about in a few slides. The patterns of lung involvement are there on the right side. There's a table on page 1117, 36-2 that outlines those patterns of lung involvement, and they're perfect. They perfectly explain those. But with that pneumonia, many times since this is such an inflammatory response, you do need to run into a course of steroids in order to manage that pneumonia. Okay, so pneumonia can be classified in two different ways: community-acquired or nosocomial. You've heard of both. With community-acquired pneumonia, your healthy patients are really not going to get community-acquired pneumonia unless they are immunocompromised in some way, shape, or form. Pneumonia can range from mild walking pneumonia, as many of you have heard, or life-threatening to the point where they're on a ventilator in complete respiratory failure. So, depending on the cause of the inflammation in the organisms, your age and your general health is really kind of what determines how bad it's going to be on each individual. And then, of course, the nosocomial, you can see all of the reasons and rationale why a patient can get hospital-acquired pneumonia. So that is just a huge reason that pneumonia can be such a complication of influenza. We really want to encourage those flu shots annually. So modes of transmission. This is classified as an airborne illness. You can get it through inhalation caused by inhaling after an infected person coughs, sneezes, or talks. Bacteria may spread to the bloodstream from an infection somewhere else in the body. And again, it can be classified as community-acquired or nosocomial. And it can get so bad that it can be seeded from the bloodstream. So manifestations, you want to be really familiar with the manifestations of pneumonia, and you want to be kind of alert of those. It's kind of these red flag ones. We're going to look at chills, fever, productive cough, general malaise, pleuritic chest pain, and we talked about the difference between cardiac chest pain and pleuritic chest pain, and that is when it is worse with a deep breath. Adventitious lung sounds, crackles, rales, possible pleural friction rub, diminished consolidation areas in the lungs. So let's see, shaking, chills, fever, productive cough, wheezing, muscle aches, nausea, vomiting, rapid breathing, rapid heartbeat, difficulty breathing. Those are all signs and manifestations of pneumonia. So some really severe complications, they can run into having an infection or necrosis involving the lung or the lung lining. Or empyema, which is it's an awful thing. You can get a pus pocket basically in the pleural space, and they have to go in and either drain it under CT guided drain, or they need to put a chest tube in to drain that empyema, and just so many complications can happen from that. Can spread, and then ultimately your patient can go into complete respiratory failure and need ventilator management. So pneumonia management, we are going to identify the cause. Do a good sputum culture. Again, we talked about sputum cultures. Do good oral care first to keep the mouth clean so we don't get the extra bacteria and it's going to get in the way of our good culture. We need to hydrate our patients with either normal saline or D5.5. We want to keep them very well hydrated with plenty of IV fluid. So of course we're going to watch all of their vital signs, breath sounds, SpO2, ABGs, like we've talked about like crazy, skin color. We're going to take a look at them from head to toe. Monitor those ABGs and manage them appropriately. Fowler's position, we're going to keep their head up so they can manage their breathing. Again, keep them hydrated, and then supportive nutrition. Supplemental oxygen is necessary, analgesics for rest and comfort, antibiotics, absolutely. This is kind of that one step further than your bronchitis. You're going to give them bronchodilators, and down the road, I'm not sure if we have it on a slide or not, but definitely maybe steroids, prednisone, salumedrol for these type of patients because of the inflammation. With those bronchodilators, if you happen to have short-acting versus long-acting, you want to take the short-acting first before the long-acting, and always rinse those your mouth out after using those inhalers. It can be kind of caustic on the tissue in the mouth, and it can leave an awful taste in your patient's mouth too. And, okay, so medication, mucolytics, chest physical therapy. If you can remember, cough and deep breathe, center Sproner, the acapella to kind of any breathing tool you can use, pneumococcal and flu vaccines. And if you remember kind of those little nitty gritty details of your vaccines, you want to make sure they haven't had any reaction in the past, any shellfish, allergies to eggs, of course, or if they're on chemotherapy, or if they have any major health issues. We really want to be careful. I think we get a little overzealous with giving our flu vaccines. In our pneumonia vaccines, we really want to ask those good questions before we give those. Okay, we're going to move on to tuberculosis and fungal disease. So tuberculosis is a chronic, recurrent infectious disease that usually affects the lungs, but can also sometimes affect any organs, the kidneys, the bone, or the brain. So the cause of tuberculosis is the Mycobacterium tuberculosis. It is slow-growing, acid-fast, waxy capsule. So what happens is that's a lot of words to say. The acid-fast, waxy capsule makes the organism very drug resistant. So if an infected person coughs, sneezes, speaks, or sings, the droplets are left in the air and live for hours. And those can be inhaled into the lung tissue. The body then, of course, wants to heal it, wants to fix it, so it encompasses it and it fills it and seals it off into little pockets. So it can infect the lungs and other organs. Those droplets can be suspended in the air for hours. and our body, what's it called is it contains the bacilli, which is where that active disease is. So TB is uncommon in the U.S., but not so much in the third world countries. According to the World Health Organization, the highest prevalence is in Nigeria, Indonesia, Pakistan, People's Republic of China, South Africa. TB death rate has dropped 47% between 1990 to 2015. That last one, the multi-drug resistant, MDR, has increased. The MDR stands for, it's called, it's a multi-drug resistant TB. It's called XDR, stands for extensively drug resistant TB. So risk factors, you can read our slide, really don't need to expand too much on this slide. You can read through what makes a patient higher risk for having TB. Think those medical and social conditions, either immunocompromised or socially in a very close quarters. So that bacilli settles in our alveoli or our respiratory bronchioli, usually in the upper lobes. Our neutrophils and our inflammatory response encase that bacteria, but they cannot destroy it. So the TB bacteria goes dormant, and it is formed into pockets in our lungs. So if the patient is immunocompromised, then the bacteria can spread. Patients have the bacteria, so they don't have active TB, they will develop scar tissue. Then this will show as a lesion on the chest x-ray. And this is a patient with a really strong immune system. They will be able to form cavities of the body tissue. It's called cavitation, so they can form in the lung as a result of the tuberculosis. So some complications you can have are tuberculum rupture. A really bad cough can sometimes rupture that tuberculin capsule, and then you are reactivating active TB, and then you can become contagious. TB can also get into the bloodstream. It can travel into the CSF, our pericardium. If we've coughed it up and then swallowed it, it can actually get into our GI tract as well. So how does it look? Tuberculosis, we do our screenings upon admission. You can kind of take a look at everything, and it's one of those kind of clustering of symptoms. A persistent cough, again initially dry, later productive, and unfortunately blood tinged. Purulent sputum with some blood streaked, fatigued. But if you're coupling this with weight loss and anorexia, night sweats, and low-grade fever, and then you kind of do a screening, have they been exposed to TB? Is there anything that, that would kind of throw up that red flag? At Methodist, if they have 2 positive symptoms, we put them in isolation until we can do further testing to rule out TB. Okay, so how are we going to diagnose TB? So I don't know if you've all had them, but there is, the MAN2 test, and it's your TB skin test. So 0.1 milliliters goes just right under your skin, and they read that area of your skin in 42 to 72 hours. If there's a positive result, there will be a bump or a raised area in that area, and then there's further testing that has to be done if that happens to be positive. It is when you're administering this test, it is just subdermal, so that needle needs to be, I would rather give an IM or a sub-Q injection than a subdermal. It's very, very difficult. It just barely has to be under the skin, almost parallel, so you can almost see the needle through the skin before injecting. This can be an indication of either exposure or active disease, and they would have to really dig in further to delineate what's going on with your patient. There's interferon gamma blood tests. Those are much more highly specific. They're expensive, so they aren't used as often, but they can delineate whether active or latent, whether, depending on what's going on. Okay, so depending on if you have a positive test. They can follow up and do a chest x-ray to identify if they have any lesions. They can collect sputum cultures, and it's called acid-fast